Welcome to the Crackin Backs podcast, where we delve into the evolving world of sports medicine and groundbreaking technologies. Today, we are thrilled to have Dr. Trent Nessler, a pioneer in the field, joining us to unpack the wonders of ViMove Plus AMI. Did you know that this technology has scrutinized the movements of over 70,000 athletes and 5,000 first responders, uncovering astonishing patterns like the increased risk of an ACL tear within 3 years following a concussion? These insights are just the tip of the iceberg. Dr. Nessler will guide us through the complexities of balancing vast data points along with clinical experience and how this synergy led to the innovative approaches in treatment and injury prevention. We're also looking ahead. With technology rapidly evolving, Dr. Nessler shares his insights on the future of objective movement measurement and its potential to revolutionize sports medicine. Get ready for an enlightening conversation that will change the way you think about health and performance. Let's dive in.
All right, welcome back, Crackin Backs. Hey, Trent, it's so good to actually put a face with a name and see you, and I'm looking forward to this conversation because you've got over 25 years in clinical experience in the world of sports physical therapy and rehab and biomechanics and all that good stuff. But what I'm really intrigued to talk to you about, because it's such a hot topic right now, is how you've seen this landscape evolve with the biomechanics, therapy, rehab,
Yeah,
especially in the context of technology.
yeah. And first of all, thank you guys so much for having me on. I'm super excited to share this passion with you and share kind of some of the stuff that we're doing. So looking forward to it.
Right on. So let's talk about the context of technology from the landscape. When you first started 25 years ago, hardly people were even using a cell phone, let alone, the Dick Tracy watch. So for those older people,
Yeah.
um, yeah. So let's talk about some of that landscape where you've seen it go, and then we'll get in a little deeper.
Yeah, so interesting thing is that I've always wanted to quantify human movement in a meaningful and reliable way. And so when I first started, I'm kind of dating myself here, but it was the big video cameras with the beta tapes in them, trying to record people and trying you laugh because like we remember those,
Oh
right?
yeah.
Trying to record people and trying to come up with a way of using 2D as a way to quantify human movement. I actually went from that to a technology
Yeah,
called Dartfish, which was used
I
a
remember
lot in
that.
professional sports. It's used a lot in coaching. So I was using that technology, but again, it was a 2D technology. And as we all know, human movement is really three dimensional. And sometimes what happens in a 2D environment is that you would see movements on 2D that really aren't there because you're not capturing it fully in three dimensions. I used Dartfish for a long period of time, tried to find ways to truly quantify it, was still struggling with that. And then Microsoft was releasing the newest version of the Kinect. And so I was actually able to get what is called an SDK or software development kit for the newest version of the Kinect camera. And we were one of the first 50 people to get this. And so we were using Microsoft programmers to program the Kinect, basically what we were doing with our eyeballs and trying to do that with the latest technology. And unfortunately, that is a gaming technology,
Hmm.
and it's great for playing games and things like that. But when it comes to capturing human movement in a very reliable way, unfortunately it's not quite there yet. And what we found is that despite all of the time, all of the effort, all of the programming, we were still getting around a 20 to 25% error rate. So eventually ended up scrapping that project. And then in 2014, 2015, I came across a wearable sensor technology that was just coming to the market out of Australia. And this wearable sensor had been validated against a Viacom system, biomechanics lab, and it was within 3% of that. And it was actually developed by a physiotherapist in Australia. to quantify movement that he was seeing with his soccer players. And there was that sideline discussion with the orthopedic surgeon, like, what are you seeing on movement versus what do you see on movement? So he was trying to find a way to really quantify that. Did a great job with the development of the sensor. And then what we did is we actually merged kind of together to develop a movement assessment that is designed to really assess the biomechanical risk factors for, primarily it was around ACL injuries. What we found is once we commercially launched it and brought it to the market, and we started to use it in college athletics, and we started to use it in high school athletics, used it clinically in the clinic, and then it started to expand into professional athletics. What we found is that when we correct those biomechanical risk factors associated with ACL injuries, what we were actually seeing is a reduction of over 58.2% of all lower extremity injuries. So ankle, knee, hip, and low back, we were seeing that those same biomechanical flaws that we were recording, that when we corrected those, that we were seeing a whole kinetic chain response to that, obviously, right? So that really was the first step. And, since we commercially launched that in 2015, we now have about 450 systems across 5 different countries, and we've collected data on over 80,000 people. And so I've always kind of been a research geek in nature. One of the things I always wanted to do with this is create a database by which I could capture mass data, because I felt like we know a lot about human movement. We know what the biomechanical literature shares with us, but in a biomechanics lab, for them to collect 1,000 subjects, that may take them 5 years to do that. And so what I wanted to be able to do is create a system that reliably could capture and validly capture human movement on a large scale. And so what we found is that we're learning a ton about human movement. So now our system, the new version that we have, captures 3,500 data points for every assessment we do. So across 80,000 assessments, we're talking about 120 million data points related to human movement. And the beauty of that is that it's teaching me so much that I never knew. I'll give you an example. So we know from the literature, for example, that if you have a concussion, you're 3 times more likely to tear your ACL upon return to play up to 3 years after a concussion. My question was always, well, why is that, right? Because, we have concussion clinicians who, they'll work the vestibular system, they'll work on balance, they'll work on their necks, and they'll get them back to play. The problem is that what we found, because we measure concussion and we measure movement, is that folks who've had a concussion, the dynamic valgus that they have at their knee is much greater magnitude. Wow. And the speed at which their dynamic valgus occurs at their knee is a much greater greater magnitude. That being said, that's the number one risk factor for ACL. So what we then do is that we can implement that knowledge into our concussion rehab, because 99% of the concussion therapists that I know don't do single leg squats. They don't do single leg hops. They don't do multi-directional hops. But based on that knowledge, we can now bring that into our concussion rehab and return that athlete to sport in a much safer, meaningful way.
That's freaking cool.
Right? That's what I love. That's what there is so much that we're learning about movement that it just every day it just blows my mind. And it's exciting because now what we're able to do is we're starting to break it down by sport, by position, by age, by level of play, Division I versus Division III versus pro, all of these different factors. Wow. Now that we can start to really start to see what are the major things that are driving not just injuries, but also performance. Because as we all know, biomechanics is biomechanics. You improve biomechanics, you reduce injury risk, but you also drive athletic performance. That's what I love.
Before we move on, I need to ask you about
Yeah.
what you had just mentioned about the valgus, the findings in valgus positioning
Yep.
of the knee and concussion
Yes.
and the relationship. This is a first for me to hear this. Yeah.
Yeah.
And
Right.
so let me just gotta ask you a little bit more about this.
Yeah.
So
Yeah. Yeah.
how
Yeah.
did how did you find this out? Did you do pre and post concussion? Did you do like a pre-testing to identify what would normal valgus or normal movement
Yeah.
patterns were?
Great. Yeah. Great question. So, the beauty of mass data is that you can filter mass data, right? So we have data on 80,000 individuals. So all we simply do is we take all of those individuals who have reported no history of concussion, and we look and see what their averages are on dynamic valgus and speed of dynamic valgus. Like I know, for example, normative values for single leg squat is around 20 degrees per second for dynamic valgus. A hop is 100 degrees per second. A hop plant, which is a multi-directional hop, is 135 degrees per second. So we know that from the normative data that we've pulled, and then we take those who've had a concussion, and what we saw is that their dynamic valgus in all of those single leg activities was much, much higher. And let me tell you this, the other thing that we're seeing, so this is really cool. So our newest version, we are now quantifying how much pelvic motion you have in a single leg activity. So not only can I measure how much does your pelvis move in like a Trendelenburg or a corkscrew, but I can also measure the speed at which that happens. So what I suspect is that there is a correlation to pelvic speed, a lack of control of pelvic speed or fall of the pelvis in labral tears in the hip. That's what I suspect, because we're seeing that same speed factor associated with ACL risk. We see that same speed factor associated with UCL tears. It would make sense that it also correlates to labral tears. That said, though, the other thing that we are now seeing, because our newest version has just started measuring pelvic motion, is that concussion factor also plays into pelvic control. And so one of the things I'm actually going to talk about at the conference is the correlation of lack of pelvic stability and center of mass displacement in loss of balance, number one, but also the valgus stress that occurs at the knee. Because what happens is that when your pelvis falls, your center of mass goes off, the force vector that it drives your knee into a dynamic valgus position. So one of the researchers that I talk a lot with is a guy by the name of Timothy Hewitt. In the world of ACL literature, he is the most published guy in ACL literature. And the cool thing is that we're seeing this in the mass data, and researchers are now starting to look at that. They're like, holy cow, there's this whole pelvic link to, or lack of pelvic stability link to risk of ACL injury. And because we've seen it so many times, now we know is that if your center of mass is displacing a large amount, and the way the force vector is, it's just driving your knee into greater degrees of dynamic valgus, and the speeds are much higher. So the beauty of that is, from a training perspective, is what to do. It's God, I could talk for hours on this. The amount of information that I have learned related to human movement with mass data capture is amazing. And right now we are capturing, because we're across 5 different countries, we're capturing data at about 2 to 3,000 subjects a month. So my goal is, in the next 10 years that we have data on over 1 million people. That would be amazing.
That would
Like
be
nobody's
amazing.
ever done that before.
That's
Trent,
so
let me
cool.
again. I'm sorry. I just got to keep digging deeper into
Yeah.
this.
Yeah,
So
absolutely.
we always were taught that simply you do a Trendelenburg test. Oh, that's a weak gluteus medius. But now
Right.
you're finding that it could be related to concussion. So how does that interplay?
So yeah. So I don't know the exact interplay. what I will tell you is that, like when I teach my courses, I teach different levels of glute medius weakness. You've got your Trendelenburg glute medius weakness. We have what's called a retro Trendelenburg, which is a little bit more glute medius weakness. And then we have a corkscrew, which is a Trendelenburg with rotation. So they're failing through the full length of the glute medius, which then guides me to a training perspective. So like in the course, one of the things I'm going to talk about is the spiral technique, which is a technique that we use with a CLX band from TheraBand, where you wrap it around the limb and you basically create an adduction and internal rotation stress through the femur so that they have to actively contract out of that. And a lot of that goes back to the motor learning aspects. Part of the principles that I apply is some of the same things that came out of like stroke rehab. And how do you create better motor planning in the higher centers by pulling things into those patterns, so they have to actively pull out of those patterns, if that makes sense.
Okay, hold on. All right, so I feel like I have so many questions for you on this. All right, so why?
I love it.
Why would a increased valgus stress post concussion, or the results of increased valgus stress post concussion,
Yep.
cause ACL problems?
Yeah. So
and not medial collateral, or
Right. So the number one mechanism let me back up for a second. The number one mechanism of ACL injuries is non-contact and orientation. And so if you look at the research related to the limb position at the episode of the ACL rupture, what the studies show, and this comes both through video as well as CT scans looking at bone bruising. And from bone modeling and bone bruises, they can tell what the position of the femur was relative to the tibia. Based on that, what they do is they go back and they do that bone modeling, and what they see is that the femur and the tibia are in this dynamic valgus position. So dynamic valgus is the number one thing to measure for ACL risk. And that's, the beauty of it is that, and I don't know why, but we started measuring that back in 2015. Now that being said, what I've seen is that dynamic valgus is important, but more important is controlling the speed at which dynamic valgus occurs. Because if you look at all of your physics formulas and you look at torque and you look at power and you look at force, they all have a speed component to it. So you and I could stand up, put our knee in 20 degrees of valgus, and it wouldn't bother us. But if you did that at 250 degrees per second, you're probably going to tear something. So there is a component of speed to it. And the beauty of that is that the other piece of that I'm now seeing is that the faster the speed, the more links in the chain that are involved. Because if you're controlling your knee, you're not controlling your knee, but you're controlling your hip and your foot, it's going to control some of that speed. When speeds are super high, what happens is that there's more links in the chain that are actually breaking down.
Oh my God.
Isn't that fascinating?
Wait, we've been on for what, 10 minutes, and I want to take the course. I want to get the equipment and buy the program and everything. That's right? Like unbelievable. So, okay, all right. All right, Terry, do we have any other questions on that one? Because I'm sweating from this already.
Yeah.
All right. So, all right. Now, do you do an evaluation on like just a visual observation and put them through some basic movements before you put the sensors on, or do you put sensors on with your equipment?
No, so it's God, it's so funny. I've had some orthopedic surgeons. So our test, it is 83 reps and 3 1-minute time tests. And I've had some orthopedic surgeons tell me, "Oh my God, that's too hard. You can't put athletes through that." Dude, if you're an athlete and you can't tolerate that, you probably shouldn't be on the field. I'm just going to say.
Yeah.
But the other reason that we do that is that, I'm a firm believer that movement degrades
Yes.
over time and as you fatigue. And so the intent of the test, what the test consists of, we do core testing. So we do a plank, we do squats, we do right side plank, left side plank. The most highest EMG activity in a side plank is your glute medius. So I pre-fatigue the glute medius. Then what I do is I have you do all single leg activities. Start with a single leg squat, it's the least challenging. Go to a single leg hop, more challenging. Then I go to a multi-directional hop, jump forwards, backwards, lateral, and medial. Of those four, the most difficult movement is jumping lateral because you're taking your center of mass, accelerating over, you land, you got to stop your center of mass from going that direction. You bring it back to midline, and at the same time, you got to control your knee from diving into a dynamic valgus. So the medial hop is one of the most telling of all four motions because we tend to see the highest dynamic valgus speeds and magnitude with the medial hop. And they're doing that at the conclusion of multiple episodes of fatiguing of the glute medius.
Man. Hopefully you don't injure somebody while you're doing that, while you're testing.
Well, I'll tell you, it's funny because, obviously, the first year I launched, man, I would have a lot of high blood pressure watching testing. So knock on wood, we've done over 80,000 assessments and we've not had any injuries.
Wow.
I will tell you, I just tested this summer. I tested 2,000 firefighters, no injuries. The part about it too is, like we test a lot of first responders with the assessment. We do it in a lot of military personnel, and there is variance. You got your extremely fit individual and your not so fit individual, in a firefighter, right? Yeah. And the guys who are extremely fit sometimes will come out with poorer scores than somebody who's less fit, and they're like, why is that? I work out all the time, like I should be performing better than that guy. But that guy, the less fit guy, he's never going to go into that fire balls to the wall. He's never going to run in there just all out, right? But the younger guy is. And that's what I'm measuring. I'm measuring, what do you look like when you're putting it all out there? Because that guy's all out there, the less fit guy's all out there is very, very different than the physically fit guy who's all out there, if that makes sense.
So you're predicting stuff. Yeah. You're predicting injury before it happens, or in this case, ACLs. Do you want to? You don't want to say that? Do you want to say that? Or?
I say I mitigate risk because predicting something that never because from a research, you guys know, from a research term, really predicting something that never occurred. How did if I could do that, I'd be a billionaire.
Right. Well, you might be on the road to being one at this point. So
right.
All right. I'm ready to. Not really. I'm not really ready to move off of this, but I'm ready to.
No, you're not. He's like a kid in the candy store right now.
I love it. You know what? And that is quite honestly, it's one of the things I love about doing podcasts like this, because I love talking to people who get it so that we can get this information out there. I mean, this is my passion for the last 20 some odd years. And the beauty of it is it works. It absolutely 100% works. And I'm not selling pseudoscience here.
No.
Okay. You know what? I have to ask just one more question about this. Because I got like 10,000 between Dr. Terry and I. We probably got 100 questions for you. But all right. So let's talk concussion, back to concussion again. And you're noticing that increase in valgus stress. But yet you also would see that in an overuse injury void of concussion, right? Okay. So
right.
What are your factors? Like, is it just the patient telling you, hey, I had a concussion last month or a year ago or 10 years ago or last week? Yeah. And that's the difference between what you're looking for?
Yeah, so one of the things that we know from the research is that risk factor can go up to 3 years post concussion.
Wow.
So we actually, so as a part of our system, we capture a lot of demographic information. For example, I know that if you've had a previous ACL injury, you're 4 times more likely to tear your ACL. So that's one of the factors that we pull in. We pull in when we get concussion, it says within the last year, within the last 1 to 2 years, 3 to 4 years, 5 years plus. What I see is at 5 years plus, we're not seeing as dramatic of a change. But what I will tell you is that it needs to be addressed from a rehab perspective. So from that was my intent of putting that question in there, because everything that I do, I want it to have some kind of clinical implication. Like, what do we, okay, so this is great information, but what do we do with it clinically? Like, how do we change that? And that's really what the that's really, for me, the reason behind the data. Because how do we clinically use that information to drive better clinical practice patterns? So you want another total brain blow?
Hold on.
Always.
Go.
All right. So so side planks. Historically, I always looked at side planks as being the exercise that I would do to activate glute medius, because we knew the EMG activity of the glute medius is really high in that. The interesting thing is that if you start down at the foot and the ankle, in most people in a side plank, their ankles stay in a neutral position. And what we see is that some athletes, they will actually move into a supinated position on the bottom leg where their tibia drops down to the ground. We call it a tibial drop. Simply, their perineals and their anterior tib is not strong enough to stabilize them in a neutral position. What we've seen is that athletes who have a tibial drop in a side plank are more likely to suffer an ankle sprain, especially in sports like basketball.
Oh my God.
Right? Right? And it makes
I'm
total
checking
sense.
everybody.
I was
next
thinking
tomorrow.
that too.
Right?
I was
Right?
thinking that also.
And it makes total sense. So go up to the shoulder. One of the things that we do is we have the person put their opposite hand up on their hip. So I can visually see that if their shoulders are rolling forward, the serratus anterior on the downward arm and the rhomboids are allowing their shoulder to come forward, which is going to increase their risk for labral tears and rotator cuff tears. Right? From a side plank. Like, who would ever guess that you get so much information from a side
Hold
plank?
on. Hold on. Could you put?
I gotta try a side plank right now. I'll be right back.
Right?
I'm tickled to death by this. Okay, because I love this
Yeah.
biomechanics stuff. So let me ask you. So side
Right.
plank, and you have them with an arm out or on their hip.
Yep.
On their
Arm
hip,
on their
right?
hip, right? Yeah.
Yep. Arm on their
And
hip.
if
Yep.
which is rolling forward that you.
So the
Downward arm.
downward arm, okay, the scapula is not
Stabilizing. Yeah.
contracting enough, stabilizing enough against the rib cage. So the upper shoulder rolls forward because it's a closed chain. So because it's a closed chain, this downward shoulder, the scapula, is not stabilizing enough against the rib cage. So the serratus anterior and the rhomboids are not strong enough to pull up against that rib cage. If that makes sense.
Yeah.
So it's the downward
So
arm.
serrated. So you said that there's a higher risk of serrated. What tears?
Higher risk of
tear.
labral tears
Okay.
and rotator cuff tears. Yeah. Right?
That's in my new exam every time now.
Right? Right? This is why I absolutely love mass data.
Totally.
It's why I love having a standardized test across tens of thousands of people, because you learn things about that makes it super meaningful. And the interesting thing is I've had some pro teams that are like, oh, the test is too long. Like, I only want to do one or two of those movements. The problem with that is that you're not capturing the full picture. Like, you're getting a snapshot. I will guarantee you, if you do 10 reps versus 83 reps, that person is going to look completely different than they're going to look at the end of the task. So it's, to me, it's not just about, it's multiple things. Number one is it's about the fatigue factor, but it's also the sequence of the tests that we've put in there. We've put them in there for a very specific reason to start to pull some of these things out.
So you're determining also RTPs or return to plays from these biomechanical aberrations, and you're able to use that as a criteria now.
Yes. Yeah. In what I tell my orthopedic surgeons is it just allows us to make better and more informed decisions about return to play. I'll give you a perfect example. One of the common measures that we use for return to sport is called LSI, limb symmetry index, comparison of right side to left side. And so, the assumption is that you are comparing that to a good limb. But we've all seen the athlete who jumps off a box and both of their knees collide together. That is 100% LSI. So from a return to sport perspective, that athlete's free to go. They're ready to go. But we all know that athlete's at high risk. So one of the things that we developed is what is called, in addition to LSI, is we measure LQI, which is limb quality index. So it's not just about the symmetry of the motion, but also the quality of the motion during the performance of the task. So we actually use an LSI measure and an LQI measure in order to make a more informed decision. The other piece that we add to that is we have a 30-yard A-cell, D-cell test that we do. So again, with the sensors on, they do a max acceleration and deceleration within 30 yards. And what it allows me to capture is not only what is the ground reaction force at mid stance, not only what is the symmetry during stance times, load during stance times, but also how are they controlling their foot as the foot comes into contact with the ground.
But you're also, for those concussion patients, you're also doing psychometric testing. I think I read somewhere on that. You're doing verbal testing and other.
So not as much. There are concussion tests that you can do, and what I would just, for clarification, I am not a concussion specialist. This is something I came across in our data. We do have a measure that we use for return to sport after ACL, and that is called the TSK-11. TSK-11 is a Tampa Scale for Kinesiophobia 11 form. And the original studies were published by Paterno, which showed that if you score 19 or greater on that test, you are 13 times more likely to tear upon return to play. In addition to that, if you score 19 or greater, you're 6 times more likely to have a quad deficit. You're 3 times more likely to have an LSI that is off. So there's a lot of measures associated with the TSK-11. One of the things that we've seen since we measured TSK-11 is one of the movements that we assess is a squat, right? So with the squat, I take a plumb line, this is how I used to do it. I drop plumb line right down the center of you. And one of the things that I was seeing is that a lot of my ACL patients who had been discharged, they've been returned to sport, when they would squat, they would still shift their weight away from that involved side. And my question was always, well, why are they tearing that contralateral ACL? Why is it that there's still a quad deficit when they've gone back to play? And so one of the things that I started measuring very early on, back in 2000, probably about 10, was what I call a lateral shift. So since we started measuring it, the research has now called it a lateral displacement of the pelvis during the squatting motion, much more articulate than I, but the concept is the same, is that athletes get used to, they build that motor pattern that they're going to shift their weight away when they're squatting down. If that is not corrected, I've seen athletes in the gym squatting 315 pounds with a 3-inch lateral shift. Now, one of the things that we found is when we measure TSK-11 and they perform poorly on the TSK11, they are much more likely to have a lateral shift because they don't have the confidence in that side.
Mm.
In addition to that, we also see that when we do single limb performance with them, they have greater magnitudes of dynamic valgus and their speeds of dynamic valgus are greater. What we've also seen that as we correct their lateral shift, as we correct their control of dynamic valgus and speed of dynamic valgus, that kinesiophobia goes down.
Kinesiophobia. Have you ever?
Yeah.
That I'm gonna use that forever. I've never even heard of that.
Yes.
Kinesiophobia. That's beautiful. Because
Yep.
just yesterday we had a guy who was with the New England Patriots. He came in and he was referred in, and I had him squat. I watched him squat, and he did. He bent forward a lot. But then I asked him, I go, listen, when
Yes.
you go back to the gym, can you take some video of you squatting with some weight? Because I want to see it challenged. And wouldn't you know it, he was doing exactly what you said. So
Right.
it was super obvious, but he didn't mention anything about it. And then
Right.
that caused us to ask more questions, and we find out he forgot to tell us about an Achilles tear on the opposite side.
Oh,
So
wow.
he's got some ankle mobility issue. But do you find out
Yeah.
these things that they don't tell
So
you?
yeah, so you brought up a great point. So lack of ankle range of motion, a lack of dorsiflexion in a squat will drive you to the contralateral side. And so one of the things that we actually have in our assessment, the very last test that we do is called the ankle lunge test. And it's simply to clear the ankle as being the driver of the dysfunction. Because the other thing is that too, is if you don't have enough dorsiflexion, when you land, you're going to land stiffer, which simply means the force that's distributed to the knee is going to be much greater. So what we like to do is we do the ankle lunge test to clear as a driver of a lot of the biomechanics that we see. Because, and too, to your point, a lot of times what we see, so we actually measure forward flexion in our squat with the sensors. And the reason that we do that is that we find that a lot of athletes who lack range of motion, maybe they lack range of motion of that operative knee, and visually they want to see like they're going down. So what they end up doing is they end up creating more lumbar flexion in order to compensate for the lack of knee flexion. Then what that does is it throws them up for a whole L5S1 issue in their low back, especially when they start squatting.
This guy was 6'5", and we put a foam pad, a thick foam pad underneath his heels, and all of a sudden he squatted beautifully.
Yeah.
And that's what gave us the clue that there's some ankle movement. Oh my God, I love this stuff. Terry, I know you want. I'm sorry, man. I just took over this whole conversation. Go ahead and ask him what you were going to ask him. Okay,
I forgot. No, no, I do have a question because you brought up some. Because I'm always going back to some of the simple stuff because it's the simple stuff sometimes that help the average doc even more. So we talked about like a lateral. One of the best things is a single lateral jump, just to look for stuff. And then you talked about how to look at side planks different and how much information that can show the practitioner.
Yep.
So those are two. Give me a third one that's a movement that most people will look at one way.
Single leg squat.
So single leg squat. What are we looking for that would cause something else is to make somebody they can incorporate in their office tomorrow can do it. Talked about that.
Yeah, absolutely. So in a single leg squat, number one is symmetry between the right side and the left side. When I say symmetry, I mean depth of motion and control of motion. When I'm looking at a single leg squat, I'm looking at, do you have dynamic valgus at your knee? And if I don't have a sensor and I can't measure it, I can still see it, right? Not only can I see it, but I can see that if that's falling in quickly or if it's not falling in so quickly. So control so one, range of motion of that activity, the ability to perform the task, number one, the range of motion during the task, the control of the dynamic valgus during the task, and just as importantly, and quite honestly, I think probably for the first 5 years or so that I was looking at movement, everything was at the knee. Like I wasn't looking at the hips. And so the third thing that I would say that I've really, focused a lot on in probably the last 5 to 8 years is control of the pelvis, and not allowing for a Trendelenburg, retro-Trendelenburg, or a corkscrew. Corkscrew is by far the worst. So one of the things that we found in female soccer players, we did a study with Stanford University in Birmingham, female soccer players. And one of the things that we found is that when we corrected a corkscrew in our female soccer players, we had a significant reduction in the amount of labral tear surgeries that were coming out of that particular program. So controlling of the corkscrew to me is also a really important piece, but really it goes back to the pelvic control. Now, one of the things I'll tell you is super interesting. Okay, so lack of pelvic control, what we're seeing in firefighters is that lack of pelvic control leads to increased risk for slips, trips, and falls in firefighters. Number one mechanism of injury. The other thing that we see is in police officers, lack of pelvic control has a higher correlation to a police officer who is going to lose balance when taking down a suspect.
Oh my God.
Because the number one mechanism for injury in law enforcement is affecting an arrest. So putting their hands on somebody and arresting them. If it ever goes to the ground, if they don't have that pelvic control, that control of their center of mass, what ends up happening is they take somebody down and they fall with them instead of controlling that fall. So to me, the probably the thing that I've learned the most in the last couple of years is the correlation of the pelvis to the center of mass and what that does for balance, etc. Which, I mean, I should have figured that out a long time ago.
All right, on that subject, I'm gonna dummy it down a little bit. Single leg squats, how you perform them against a wall in an open area?
No, that's a great question. So no stability. Very rarely on the field is anybody putting their foot up against the wall or anything like that. The other thing is that every time I go to do a single leg squat, they want to do a pistol squat. So a pistol squat is great for your quads. It's great for isolation of your quads. But the position that we put somebody in is what we call the athletic position. So the contralateral limb, the knee is bent, and the hip is either in neutral or slight extension. What the studies show is that position with the contralateral limb requires more glute medius contraction on the stance leg. So by placing the leg forward, because you got to think about it, as you place your leg forward, your center of mass drops backwards. It's part of the reason you get such a great quad contraction. On the other hand, most ACL injuries are occurring when someone is not in that position. They're more in a running type of position or cutting position. So what we do is by taking the limb into slight extension, you bring the center of mass slightly forward. Therefore, what it does, it causes an increase in glute medius contraction. So I call it the athletic position. That's what we refer to it as, but it's simply the knee is bent and the limb is in neutral or slight extension.
Oh, God.
The non-squatting leg is
correct.
All right, so you're not doing that full leg pistol or not even dragging it behind you, just trying to keep it in neutral.
Their
slightly.
Foot is off the ground. Yeah, that's another great point. The foot is off the ground. We do 10 reps. We keep the foot off the ground the whole time because, one of the challenges that I had is how do you quantify loss of balance, right? Some people, if I do this, it's loss of balance. Some people, I have these big dramatic movements, that's loss of balance. So in order to objectively measure loss of balance, I had to come up with a way to do that. And the way that we did that is if you touch your limb on the ground or you touch something to stabilize yourself, that is considered a loss of balance. Everything else, because what we see is, I was just we tested 100 firefighters yesterday. And you'll historically have somebody that get on one side and they're like, oh, my balance is horrible on this side. Well, that's not typically a vestibular issue. It's not really a balance issue. It's a stability issue. Because as soon as they stand on one leg on one side, their pelvis drops, their center of mass moves, and they lose their balance. So it's not necessarily a loss of balance as much as it is a lack of stability of the pelvis driving that center of mass to move.
How far down are you having them squat?
It's a great question. I typically tell them within your comfort zone. Okay. And the reason that I use within your comfort zone is because when people do that, especially post-operatively, sometimes they will modify the range of motion on their operative side because that's people subconsciously figure out this is where I can control my knee. And then if there's a variance between that on their contralateral side, then I know that that's something that we have to work on. Typically we're looking between 35 to 40 degrees.
Okay.
Our data shows that it's average around 36 degrees.
Wow.
Oh my gosh. Trent, are you able to be candid about the FMS functional movement? Because functional movement screening to me,
Yeah, absolutely. If you ask me to be candid, I'll be candid.
Go ahead.
So you know what? If you pull the research related to the FMS, what it shows is that it is not a very good tool. There was a great study published by Bushman, and what they did is they looked at over 1,000 military personnel, and they did FMSs on them, and they found that those that were at risk, the area under the curve. So when they plotted it, the area under the curve was greater than 50%. What that simply means statistically is that 50% of the time they were wrong. They were wrong about quantifying them as risk, and they were wrong about quantifying them not at risk. So anybody can look up this paper. It's by Bushman. I want to say it was in the American Journal of Sports Medicine. I want to say it was around 2010, 2012. 1,000 military personnel, very large study, very meaningful study. And the authors actually said in the detail section, in the author's comments, that if you are using this as a risk assessment in the military, you have got to be super cautious. It's part of, quite honestly, what led to the FMS starting to deviate and start to do the SFMA and all these other pieces to it. At the end of the day, the FMS does not measure the number one risk factor for injury, and that is dynamic valgus, pure and simple. So if you go back to the literature, starting back as early as 2000, all the way to 2023, and you talk to Chris Powers, Timothy Hewitt, Greg Myers, all of the major published people related to ACL risk, biomechanics, they're all going to tell you dynamic valgus. The FMS does not measure that.
We had an interesting experience.
How much more?
No, I am. If there is any,
I got about 7 more studies I can cite.
If there's any one thing that I was looking forward to is Alice asking you about this, because what you're doing seems so much more advanced, and I always had a bad feeling about FMS, but they sold it well, and you had athletic trainers diagnosing and treating, and that would put the sorry, not the athletic, the strength and conditioning coaches they were using the system, completely, and the athletic trainers were having a little problem, at the pro level, and so it caused some conflict. But we saw a couple athletes where they forced them to assume the positioning that FMS suggested, like in a squat. They never took under consideration things like retroversion of the hip or antiversion, because we're not all the same. So you would have guys squatting with one, this was comfortable if their feet were in this position, and they ended up injuring them. They ended up, having hip pain from doing the squat the way the FMS told them to do it. Anyway, so that's
so good on Spencer. Look at that.
I asked a question. I asked Trent the question, thinking that I have a funny feeling he's going to rip on this. I loved it.
Yeah,
That's great.
Well, I'll tell you, to the FMS's credit, it was the first tool on the market that really, quite honestly, brought awareness
Yeah.
of movement and the importance of movement. I think, from that perspective, it really quite honestly, it revolutionized the way that we look at movement. That being said, to your point, I think it was very well sold. It was very well marketed. And unfortunately, it's created a culture of cultness
Yeah.
around it that people just don't
Yeah.
want to move away from it. And the literature does not support it. I mean, if you look again and again and again and again, there's multiple studies that show that the predictive value, the positive predictive value of the FMS is less than 50%. So you could flip a coin and have a similar response. That being said, with technology, that's one of the reasons that I was so adamant on creating a way to objectively, reliably measure both with inter and intra rater reliability, because that's one of the big flaws with the FMS is inter and intra rater reliability, number one, and number two is sensitivity. How do you have a test that you can perform 2 reps? Like if you performed all 3 reps horribly on the first test, you performed 2 reps well, in the last rep horrible on the second test, you've improved 66%, but your score does not change. So from a sensitivity perspective, it's not sensitive enough.
Oh,
Whereas on our assessment, we're looking at 3,500 data points, and the overall score is 560. I think it's 565 points. So you can make minor changes in your results and see it reflected in the scoring.
all right. I'm going to sleep well tonight after this conversation. Let me. I want to ask another question before we go into our our rapid fire questions. But hang on just a second here. I do want to know about dorsal VI, and I mean this program that you're referring to that we've been referring to this whole time is ViMove and AMI. Is that right?
Yep.
Right.
Yeah, it's the Dorsa V, and it's ViMove plus AMI. So the V plus Move AMI is the product that I co-created with Dorsa V. Dorsa V is they developed the technology, they developed the sensors, and the algorithm behind the sensors, et cetera. And then what we did is we co-created the movement assessment, which is in for Dorsa V is their number one selling product.
Okay.
And which has allowed us to capture this data at such a massive level.
And actually, you just said something that I was curious about. Now, there are sensors you put on, because I've actually seen like 5-6 years ago systems that were able to identify anthropometric or limb length and where your knees were and hips and all that without putting sensors on. But you're
so that goes back to the Connect. So unfortunately, and again, I don't want to step on a time bomb here, but what I will tell you is there are markerless based systems that program out the flaws that you won't see. You won't see it because it's programmed out. Now the Connect, which is one of the systems that's used a lot for those, has about a 20 to 25% error rate. But the programming, you'll never see it because it's programmed out. The most accurate measure right now, as it is today, is a sensor on the limb, and that's what we use. It's 4 sensors, one on thoracic spine, one on lumbar, and then one on each tibia. And from that, we're within 2% of a Viacom system.
All right, cool. All right. Okay, this is great. But we're going to enter our rapid fire questions right now.
Okay.
And
awesome.
It requires you, obviously, based on timing, it's going to be, well, we won't be sounding off that bell, but we
yes.
But we are going to ask you for brief answers, but you know what? It ends up we get hung up
Yep.
on some cool answer you
Yep.
give, and we start elaborating on it. But
Yep.
all right, rapid fire question number one: what is your favorite wearable and why?
Wow. I'm going to say Dorsa V because it's taught me so
Ooh,
much.
yeah.
I mean, I hate to say that, but it has taught me so incredible. It's changed my clinical
No kidding.
practice immense. It's been the biggest change in
The
my
Dorsa
clinical
V.
practice.
Okay.
Perfect.
Yep.
Number two, you're traveling. What is your
Yep.
wake up good morning routine?
I wake up at 3 a.m. no matter where I'm at. Go
My
to the gym.
dude, right on.
And typically we'll get about an hour, hour and a half workout, and then I'll try to hit a jiu-jitsu class for an hour, and then that's how I start my day, by working out and choking people.
And then you go to heal them later in the day. Right.
Yeah.
Yes, exactly.
Terry,
exactly.
go ahead and tell him why you gave me that look.
Yeah.
Gave him that look when you said 3 o'clock in the morning.
He gets up at 3 o'clock in the morning. I won't even get up to pee at 3 o'clock in
Yes.
the morning. So
Yes.
Wait.
So yeah, when we're in Vegas, you guys can go do
Yeah,
your
exactly.
BFFs 3 o'clock in the morning stuff. I'll
Yes.
meet you for
Oh
coffee
my
and
God.
breakfast
There you
at
go.
That's
9.
There you go.
That's hilarious.
That's
Question
awesome.
number 3. Since Dr. Terry was in the movie Karate Kid, his favorite martial arts routine is waxing his cars. Wax on, wax off. What's your favorite martial arts exercise?
What's my favorite martial arts exercise? I would say a Turkish get up. Turkish get up because it's great for what we call a technical get up. So once you get knocked down, popping up real fast. I'm an older athlete, so I've got a lot of these younger guys coming at me really quick. So I got to be able to pop up real quick. So a Turkish get up.
I got challenged by my girl to do Turkish get up, and I look like I looked my age, and I'm going to practice that more often.
Yeah, I just looked like a turkey.
Question number 4.
That's
when
awesome.
you're stuck in a rut, what do you do to get yourself up and out?
You know what? I pray. I'm a big, I'm a big believer in a higher being, in God, and I look at the things that I'm thankful for. I've got a special needs child. I've got a young man, 19 years old, who's going off into PT school. I've been married for 31 years. You can't give up the things that are, the blessings in your life.
So good.
Love that. That'll get up for.
It's got goosebumps from that.
I'm not gonna get up. I won't get up for a Turkish get up or 3 o'clock in the morning. But
that's great. Thanks, Trent. I got number 5 for you. What's the one habit you wish you could break?
That I wish I could break? Being obsessive. Like, I am so obsessive about working out. I'm so obsessive about my jujitsu that I don't give myself enough time to heal. Quite honestly, matter of fact, I'm sitting here. I just had just torn my PCL, my LCL, and my meniscus, and I had surgery 4 weeks ago. So I'm in my recovery phase right now.
So, are you a patient of your are you a patient of your ViMove or your ViMove?
Yep. BFR, all of it, laser.
Oh my
all of
gosh!
It.
Oh, all right. Well, that's good, man. I hope you heal quick from that.
Thank
all
you.
right, we got to wrap it up. But Dr. Terry, you know what I'm going to ask, right?
Oh, I know.
Can we have him on again?
Go ahead. Yes, we'll talk about that after the show. But so I do have one question. So I do want to wrap this up. Because you have to go to your rehab and all that, but you've had such an impactful. I want to hear some personal motivation. You've had extensive, impactful career, medicine, research, injury prevention. What's the driving force, and to push the innovation and improvement in this field? And before I answer that, I want to answer it for the person listening who may be either starting out in their career or is burning out.
For me, it was pretty easy. My father broke his neck when I was 10 years old, C5, 6, 7 burst fracture. Got him, I came out of PT school. We got him up and walking again, and he was in an automobile accident, thrown from a car, suffered a C1, C2 spinal cord injury. And my dad has never given up. My dad started a construction company and then had his first spinal cord injury. And from a wheelchair, built that into one of the most successful contracting businesses in Arizona. After his second spinal cord injury, still in a wheelchair, complete quad, he built it into one of the largest in the country. And, he never told me, but what he showed me through his example is that you can do whatever you put your mind to. If you are determined enough, you're persistent enough, and you work hard enough, you can achieve anything. One of the things that I would say is for the young people out there who are looking to get into the career is, I have my CV that I send off to people, and I have my CV that I don't send off to people. My don't send off to CV is all the things that I want to accomplish, and I write it down. I put it as if I have accomplished it, because I'm a firm believer that if you write it down and you believe that you've accomplished it and you're going to accomplish it, you will accomplish it. So I don't know if that answers the question, but it's.
Oh, it definitely answers, and that inspires, and I really appreciate that. I can't wait to meet you, man. I'll look forward to it.
I can't either.
We're going
in the gym in the morning.
Yeah. And I'll see you for breakfast afterwards.
Exactly.
We're going to get you to do a couple single leg squats, Terry, at breakfast time.
Oh, well, I'm starting now, and the side plank.
There you go.
Hey, Trent, it's an honor to see you. Thank you so much for being on the show, and great words, and for everybody listening. So can't wait to see you. Have a
Can't wait to
blessed day.
see you guys.
Thank you.
Thank you for listening to today's episode of the Crackin Backs podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.